All right, awesome. Welcome everyone to today's webinar. So sorry for all of the technical difficulties. This is Heads Up Exploring Concussion Injuries and How to Best Support the Injured Workers Recovery. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts, in collaboration with Dr. Joshua Helm of Greater Boston Performance Care and ChiroPro Performance Center. We're excited that you've joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay, along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and helps us in planning our educational resources. We're excited to host today's webinar, even though we have started a little rocky, and we do look forward to an opportunity to partner with you. To kick us off, I'll pass it to our host, Cynthia Borbo. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services and has worked as a Massachusetts registered nurse, certified rehabilitation nurse, certified nurse case manager, and certified nurse life care planner for over 3 decades. Cindy, it's yours.
Very good. So thank you all for joining us today. Can I just say, thank God Gigi straightened out the problem, because you don't want me to be running IT. Definitely not. So we should be fine now. Now, before I hand this over to Dr. Helm, I'd like to share a little bit about the Injury Insight program. Injury Insight is a 4-part webinar series designed to educate claims professionals, human resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses and the road to recovery and potential obstacles, and answer your toughest questions. So get your questions ready. This session is all about concussions. We're taking a deep dive into concussion rehab and exploring everything from the range and impact of injury to treatment methods and what to expect, and what we as industry professionals can do to support the injured worker. For this session, Heads Up Exploring Concussion Injuries and How to Support the Injured Worker's Recovery, we're pleased to have physician specialist Dr. Joshua Helm of Greater Boston Performance Care and ChiroPro Performance Center. Dr. Helm has served as the clinic director for over 4 years, with a primary focus on sports injuries, concussion rehab, functional neurology, and vestibular disorders. He completed his clinical education through the U.S. Department of Veterans Affairs in Western New York, where he was first exposed to brain-based treatment strategies and the exceptional nuances in patient outcomes. Dr. Helm acquired the board certification from the American Chiropractic Neurology Board in 2020. The neurological aspect of care and its effect on the recovering athlete has always been a crucial focus of Dr. Helm's in creating lasting improvement in his patients. Growing up in Bethlehem, New York, he found his lifelong passion for martial arts, Aikido, Judo, and Brazilian Jiu-Jitsu. Dr. Helm has made it his mission to find the most effective treatment strategies to bring individuals out of pain and dysfunction and back to doing what they love. In his free time, Dr. Helm enjoys spending time with his wife and puppy, Ori. So take it away, Dr. Helm.
All right, you're free to share your screen, Dr. Helm.
Okay, Gigi, am I all set here? Are you guys able to see my presentation?
We do. We don't see you.
We can, and no, we don't see you, and it is on the first slide, and I think we're starting at 5.
Absolutely. We'll get the video up here. Hello, all. How's that? Better?
Perfect.
Yes,
Perfect.
we see you. Perfect.
Excellent. So just hopping in front here, back to the slide. Perfect. So, well, guys, thank you so much for having me today. I deeply appreciate the all of your time. These concussion cases have presented such a quagmire for the work comp community, and frankly, just finding good help for these individuals that have done the protocols, done what they're supposed to do. They're still dealing with post-concussion syndrome or some type of concomitant from that, and they're just left with no options. So we deeply appreciate your time to walk you through what we're up to and how we help people with their concussions every day. So this is our, I'm so proud of this picture. This is our main waiting area where our individuals that have come through the clinic that have had an excellent experience will often write us a little note just saying, you know, thank you so much for getting us back to our life, blah, blah, blah. So we're very proud of that. There's a couple personal items throughout the presentation I'll point out. So we're board certified chiropractic neurologists, and we specialize in all kinds of neurological conditions. But most people do seek us out for concussions, specifically some of the worst concussions you can imagine. So, and all the corollaries that come with that. And the functional component of our rehab is really what we want to dive into today. So the paradigm behind functional neurology is neuroplasticity, and it's basically the idea of the body and mind rewiring itself due to novel input, new input. And this is how we help our patients. We use a three-step approach for structure, function, and fuel. So we look at hard lesions. So people come in with MRIs, X-rays, CT scans, you name it. And we're identifying pathology in the brain or in the nervous system, looking at how those structures are impairing function, which is the next section. So function is like the software and structure is like the hardware. We need to consider how the body is operating in itself moving forward in time. And last is fuel delivery. So that's your oxygen carrying capacity, your vascular concomitant. So anything that has to do with vascular perfusion to the brain. Sometimes people are not getting adequate fuel delivery or they're having an inappropriate vascular response after concussion. This can happen in the brainstem. It can happen as an autonomic variable. So all of that is considered in what we do. So neuroplasticity, you guys have heard this word before. It's a buzzword that is often used in the basically all life coaching today, right? So we have this concept that we can rewire our brains based on novel input, doing things repetitively, things like new exposure that our brain is essentially adapting to new input to create a more healthy state. So health is basically synonymous with being able to adapt and change. And to the degree that we do that appropriately is our health. So if someone can adapt very fast and very effectively to whatever life throws at us, any insult we can imagine, from hot to cold to viral to bacterial, anything that can happen to our body that stresses us in any way that we adapt to is considered a neuroplastic change. And again, this is what the system we're using and working with to help rewire essentially someone's brain back to a state of health. So the brain is concerned with two questions. Where am I relative to my environment? And where is my environment relative to me? So the brain is constantly assessing safety and trying to figure out, am I safe? Am I perceiving my world in a way that makes me feel okay about where I am? The most basic life functions, long time ago, before we became human in the evolutionary chain, living organisms were moving away from negative stimulus and moving towards positive stimulus. So it's a very, very primal reaction to our life to be able to assess our environment and perceive safety within it. How we do this and the degree to how much energy it takes to do that will often dictate our health and how fast we're able to recover. So we use three systems to figure out where we are in space. We use our visual system, our vestibular system, and our proprioceptive system. We do have other senses, as you guys know, but predominantly these three are going to be the main way that we cross-reference input to determine if we're safe and if we can proceed athletically in the environment that we are stepping foot in. So you can imagine someone that is perceiving their environment really well, and they're loose and active and engaged, and their body's permitting them to be athletic. And you can imagine somebody that has an issue with their sensory input, so that they are guarded or tight or apprehensive, or have high anxiety, or have a whole host of concerns that can happen due to aberrancies in sensory input. So when we assess a patient, we're concerned with how the visual system, the vestibular system, and the proprioceptive system are working together to give them a map of where they are in space and where the environment is relative to them. When these systems don't communicate well, or you could think about them as giving different inputs to the brain, we have what's known as a sensory mismatch. You can imagine someone that is perceiving within their inner ear that there's somewhere in their vestibular system that their eyes are not matching up with their vestibular system and their visual system. So in that case, someone might turn their head or try to compensate in some way by tightening their back, or they move their shoulder forward to create a match. So to put themselves in a position where everything is telling the same story, so to speak. And that happens to create compensation so that the person feels safe and they can understand where they are correctly and move forward. Just like a crutch, over time, these systems can become more and more wound up. You can think about it like a patient becoming more and more compensated, more and more dependent on these crutches in their musculoskeletal system, or their visual system, or vestibular system. And you can operate and move through life like this with fairly high accuracy and competency until you can't. And oftentimes concussions are an isolated event that create changes or aberrancies in these systems. And the way the body responds and adapts isn't necessarily the best approach for your body going forward. So you may have found a way to survive, but you're not really thriving. So the structure of the human brain, I like to point this out. A lot of individuals have some neurotraining. It's very cool to understand how Mother Nature put together our brain, our cortex, our midbrain, our pons, medullary areas of the brainstem, and how it's organized is millions and millions of years of evolution, and why it's set up the way it is really, really quite cool. Most of the systems we're working on in functional neurology are in the inner brainstem and the pons in the medullary area down in these regions, if you guys can see my cursor. The cortical regions up in the top of the brain, that our forebrain, that makes us most human. So you can imagine our higher order functions, public perception, guilt, shame, things like that. As you work your way towards the limbic system, they become more emotional and more autonomic, meaning more integrated in a way that we aren't controlling. So as we observe a patient, we're always concerned with hemisphericity, if there's one side of the brain or area that's not working quite as well as the other, parietal versus frontal distributions, if there's cortical mapping problems in the temporal lobe. But then we're also concerned with how we're integrating smooth and coordinated movement, how our speech is affected, how emotions are perceived and affected. All of this is happening in different regions, and cross-referencing what all of their symptoms are can help us to pinpoint exactly what type of therapy might be helpful for an individual. This is a picture of the brainstem. So in the functional neurology world, 30, 40 years ago, when patients were working with receptor-based therapies to make influential change on patients so they could feel better, we started with primarily the frontal regions of the brain and worked contralaterally to the cerebellum to try to work on motor input and motor output. What we understand now is a lot more research has pointed towards the brainstem as really the primary autonomic driver. So much of our real progress in physical therapy or in any type of coordinated attempted effort to improve function for our patients is really happening at the autonomic level, and your brain is constantly assessing safety. So it's really important to understand these pathways, how they work together, and what's really happening in physical therapy and in chiro or whatever intervention you're doing for your patients. What's happening is the brain is trying to decide the fastest and safest way to create a change so that you feel you can move forward in your life with little energy. And we're always trying to conserve energy. So when we look at the brainstem, we're looking at largely autonomic systems. We're looking at things like cranial nerves, things like cerebellar pathways are the way we're perceiving visual input and reacting to reflexive motor control. So on the left side are these warm colors. Of course, these tracks are mirrored on both sides, but on the left side, it's demonstrating the motor pathways. These are going to be synonymous with pathways that are going from your brain to your hand or to your foot or to your heart or to smooth muscle, cardiac tissue, anything that is going to control movement or motion or your ability to react to your environment, right? Even if it's happening automatically. On the left side, on the right side, we're seeing the cool colors there. Those are going to correlate with the sensory pathways. These are inputs coming back to your brain from your body. Again, these are how we perceive our environment. And if these tracks or areas of our brain have any type of disturbance in them, from a chemical irritation to a viral attack to you hit your head on the pavement, if this input is if it's not getting correct information back to your brain, you're going to perceive that information inaccurately and create compensation. And then the motor system that leaves the brain to come down and control the body movement in relation to that is going to be an overshoot or undershoot, or in some other way inaccurate. And that's how we get things like resting tremors or guarding patterns, tightness, people that note that they can't feel things appropriately, they can't react well, their reflexes are messed up. We have changes to muscle spasms or you name it. So we have largely a system moving to the brain and then going from the brain. And again, the main point of this slide is just to demonstrate that a lot of this is happening at a subcortical level. We're not controlling necessarily how we're responding to our vestibular system and how we're bracing and guarding. You have to work in the autonomic nervous system and in the with the vestibular nuclei to make these type of changes. Most patients are trying to train through volitional movement. So they're going to PT, for instance, and doing straight leg raises, which are excellent, and you can create motor control that way. But that's from your big brain, right? Your frontal lobe is coming down saying we have to do this. We're talking about subcortical structures here. And unfortunately, this is the type of stuff that concussions affect and why it has proven so difficult for practitioners. I find this slide to be interesting to demonstrate how much our brain is really controlling basically everything we work on and have at our disposal. The first slide here, this is called spectrography. It's an imaging technology that is not utilized in Massachusetts to my knowledge, but it does demonstrate cross-reactivity in the brain. And I find it really interesting to demonstrate the difference between sighted control and this is called cerebral visually impaired versus ocular blind. So in slide A, we have for lack of a better term, like a normal brain, someone that can see and perceive their environment correctly. And in the middle, we have someone who is blind in their eye. So this person has optic neuritis, you may know from MS. And the slide all the way to the right represents somebody who's actually had a brain injury. And comparing B and C is interesting because B shows you that despite not being able to see at all, that person has tremendous cross-reactivity in the brain. And slide C, someone that actually can see that has brain trauma is demonstrating the level of uptake there is highly depreciated, intense demise. So we like to show this to demonstrate how much of this activity is really just brain. Everything is your brain. Your brain controls all other systems. So the visual system here, I think this is interesting to understand how the brain perceives visual input and how much real estate is dedicated to the visual system. We're really, really highly visual characters and creatures. Our brain has created the most intricate pathways imaginable, from the optic disc, the optic chiasm, back through the radiation to the occipital lobe, and how that connection correlates to temporal and parietal distributions in the brain. So we know our temporal lobe is primarily responsible for things like smell, temporal planning, so spatial planning in over time, we know that it works on intricately with the limbic system and controls our emotional responses to, again, things like smell or sound localization. It's very tied into the balance centers of our brain and how we perceive our vestibular input from our inner ear and also auditory. So how that connects with our eyes and how our brain, again, just developed real estate so that everything needs to be next to each other, It's really amazing. The parietal lobe is largely responsible for our where. So where are things, where am I, where is my environment? Temporal is largely the what, like when you say, what is her name? I forgot her name, or what color is that, right? So these systems, you can imagine, are both highly reliant on the visual system, but then have to be able to differentiate. So Gigi, we are going to pause there to introduce our first question while I remember. If you can prompt that for us now.
Sure, Dr. Helm, would you like me to restart with the sensory or go ahead with the Troxler effects?
I think the sensory, this would be a good place for the sensory question.
Okay, awesome. Well, we invite you to participate in the poll. Which of the following is not a sensory input? Let's see what you know. Okay, we've got about 22% participated. If we can get it up to 100%. All right, and we're gonna close this poll in about 4 seconds. So let's see if we can get some more participation. All right, closing in 3, 2, 1, and let's look at the results.
Excellent. So if you could just leave that up for a second, Gigi. So most everybody got that right. The motor system is naturally the complement to the sensory system. It's the equal and opposite, right? So for those of you that selected visual, visual is among the sensory inputs. We have visual, vestibular, and proprioceptive coming in, and then motor going out. So thank you for that.
Awesome.
All right. So we talked about the structure of the brainstem, the visual system. Next, we're going to introduce the Troxler effect. So one of the aspects of our therapy that we do is identifying which of the 3 systems might be most affected, which systems are performing well, to figure out what type of therapy might be relevant for a patient so they can feel better fastest. One thing that happens a lot with our patients is that we have what's known as a visual contamination. And that is when you test a patient's balance. We use CAF's osteography. It's a gold standard for balance testing. And we'll be able to determine that paradoxically, they actually get better with their eyes closed, hypothetically. So someone could say that most everyone should have better balance with their eyes open. You can imagine a case where someone would improve with their eyes closed. That would indicate to us that the visual system is primarily the problem. And we would take a more in-depth look at the visual system. So in the event that that's happening, one of the effects that could be happening is an issue with gaze stabilization, where a patient will have a problem visually fixating on a target. They move their eyes around too much. And that could be happening for a host of reasons in the brainstem that would promote too much ocular shift or inability to stare forward in space. So we use a Troxler effect. This is just a silly example of something we might do in the clinic here. For those of you guys who haven't figured this out, you're going to try to stare at that center X, the center crosshair there, and kind of look through the crosshair such that the pink dots appear to disappear, right? So you're going to perceive what looks like a green dot going around the ring. That's actually not there. Your brain is doing that on its own. And the ability to keep your eyes fixated, gaze fixation, will promote the illusion of the pink dots disappearing. And there's some real world feedback for yourself there. If you're unable to do that, or you're unable to see what I'm talking about, that would demonstrate that you have a good deal of ocular shift. You might not be able to gaze hold or create gaze stability for yourself. So we like to use this because the patients can immediately feel the change and note the progress in real time. So they can see when they're effective and when they're not. So I'm going to pause there and can introduce question number 2 whenever Gigi's ready.
And there it is. Troxler FX is used primarily for, let's go ahead and see if we can get closer to 100% participation this time. If you guys were able to try the gaze, that was pretty cool. The dots went away for me. All right, let's see if we can get a little bit more participation. We will close this poll in about 5 seconds. All right, closing in 3, 2, 1. And there are the results, Dr. Hell.
Excellent. So about the same distribution as last time. Most of you are nailing this. So yes, that'd be for gaze stability. We're trying to encourage someone to get some feedback for themselves about how well they're able to keep their eyes still in space, because the effect will not happen unless they're able to do so. I suppose attention span was an interesting secondary because that's also somewhat true. So moving on to the vestibular system. So this is the second of 3 of our main systems we're using to figure out where we are in space. Again, for the reasons we said, it's so important that we know that when we're beginning to do rehab and helping someone feel better. The vestibular system, for those of you that are unfamiliar, works, if you can picture that outer ear, it would be someone's right ear looking into the canal. We have the cochlea, all the semicircular canals, and the vestibular nerve. So what's happening there is we have our loops. Basically, the semicircular canals act as apparatuses to perceive movement in space so that we can react appropriately. So it gives us some awareness of where we are. I often liken it to a cup that's filled with water. When you spin the cup, the water doesn't move inside, but the cup moves around it, right? So we can picture what's going on in the semicircular canals. There's actually these little hair follicles that extend out into the tube. The tube is filled with liquid, cerebrospinal fluid. So when we jerk our head or move our head in a certain motion, those hair follicles, the water inside is moving, or the liquid, and that's creating movement of the hair follicles, which communicate to the nerve, goes to our brain. So we're able to perceive these movements in space with those canals in terms of yaw, pitch, and roll, so that we know where we are. Similarly, there's one that's not mentioned here, is known as an otolithic component. So that perceives bob and heave, but it's the same concept. We're using this liquid apparatus to determine spatial movement, which is really amazing that nature figured out how to do this. This diagram to the right is showing how that integration on the nerve is communicated to the brain, and then the brain responds by contracting motor, basically motor output back to the body from that synapse from the inner ear. So a lot of these systems are happening without you thinking about it. This is just your body responding to balance and changes in your inner ear, and responding by tightening your quad or tightening your glute. Again, we want to work in this system because this is the system that is affected. Not to say we shouldn't get strong and work on our squats, right? So vestibular therapies have taken on a really integrative approach for most conditions. You'll see physical therapists, chiropractors, OTs, everyone you can imagine doing therapy, leveraging the vestibular system into musculoskeletal practice. Of course, it's also highly utilized for direct neurological rehabilitation. One thing that you'll see in some of the more advanced clinics are what are referred to as gyrostims, which is what this lady is sitting on here. There's also several other variants of this, but basically this allows us to spin patients and look at ocular changes due to gravitational pitch and roll. So you can imagine we turn somebody in a chair or bring them upside down or forward to give an appropriate input to the vestibular system so that we can leverage a change that we need for the brain to adapt. So it's really cool. Some people in their clinic are using a good old spin chair. You miss the forward and backwards component with the spin chair, but it does hit the horizontal canals, which is nice. So you can imagine someone that might visually fixate on a bead or a stick and then spinning them so they have to keep their eyes still on the stick while spinning, can promote a sense of what is referred to as vestibular ocular reflex, or in this case, we're creating gaze stability while spinning. So the last system, the proprioceptive system, this is really important to understand. This is primarily what your traditional PT or chiro or OT or what have you is working in. This is the system that we most intuitively understand but can't explain. So as an example, this is like when people say the term proprioception, it's like close your eyes and tell me if your arm is bent, right? It's like, yeah, I know it's bent. It's like, well, how do you know it's bent? Well, I just know. And that I just know is proprioception, right? You don't have to go to great lengths to explain it. It's your body, it's your awareness of yourself in space, to the degree that you are aware of yourself in space, and your ability to feel and perceive accurately. And this is really, really important for, again, assessing our safety and really being able to make changes for people. Most of you, for those of you that are case managers, you can kind of ballpark when you meet a new client or patient, you can say, geez, I know this is going to be a tough case. This is not, you're already interested in reading the type of person they are and potentially how aware they are of their own body, because you know that rehab is going to be harder if someone just has no clue where they are in space, if they just can't figure out, they have no feedback from their own brain into their own body, it's an uphill battle, right? So we have to improve this system. We have to work in this model and consider where they're at, where they need to be to feel appropriate input to do therapy that's actually going to be effective. So different ways we can give stimulus to the body to control brain, because everything that we do in the body has a correlation in the brain and vice versa. So we use vibration, we use hot and cold, we use graphesthesia, which is considered basically like if I drew a number on your hand, on the palm of your hand, and you had to guess what the number was, or I drew a letter on your foot, right? So you're communicating via touch some higher order exclamation from the temporal lobe. So you have to be able to not only feel it, but then communicate back what it is that we're drawing on you, right? So deep pressure versus light touch, you understand there's different receptors that feed back to the brain. Some people have lost this sense of vibration, but they've retained deep pressure. They may not feel a burning stove, but they might feel a pinprick, right? These are important differentiations for rehab. So isometric holds are a common integration technique for cerebellar-derived issues. Sometimes people will present with motor coordination problems, tics. They might have a hemibolism or some type of motor output where they're like a dystonia. You've seen the cervical neck dystonia. So what we'll often do is work on the Purkinje, the inhibitory centers of the brain, to control output and titrate ever so more gently, like exactly how much output is needed so that we have appropriate movement without an excess of movement. You'll see that a lot in the functional neuro world. Okay, so an overarching theme here for consideration. So we want to work within the metabolic capacity of every patient. So that means every patient comes in with a threshold, and we know this as case managers, et cetera. There's a certain amount that everyone can take, and everyone is different. And some people, it's like the world's going to end if you do the smallest thing. They're just like totally can't handle it. And some people won't be honest with themselves or tell you when things are too much. So there's the subjective and objective component of this. But basically, you want to get very, very, very good at having that intuition about exactly how much to push so that there's a healthy plastic change. The brain is adapting, the brain is learning, the brain is being exposed to novel stimulus that is in that healthy capacity zone. They're feeling better. They might be feeling challenged, but they're not fatiguing. Their heart rate's not spiking. Their oxygen's not going down, right? We're working in the range where they're going to go to bed that night and feel better the next day. They're not going to be absolutely pushed over the limit where they have to spend the next 3 months in a dark room, right? So learning that exact zone is perhaps the most important thing you can do as a practitioner. So the overall affect speaks to their own gumption about how they handle stressors and how they work through their experience. Some patients are not aware of themselves, as we discussed, and some are not honest with themselves or you about their level of fatigue. Posture is a good giveaway, right? We understand serotonergic pathways and how basically upright posture and our way that we hold our shoulders back is going to dictate basic levels of fatigue and how willing we are to deal and contend with challenge. So we have receptor-based therapies that we mentioned, how we implement therapy to create change in the brain, but also how we layer certain therapies together thoughtfully to affect even more specific areas, and how we get very, very creative with our therapies and what we're doing. Just to give you an example, the other day we were working with a patient who has a dopaminergic tremor. They're not considered Parkinson's, but they are on the spectrum of substantia nigra problems, right? So we had tongue stimulation going, rapid peripheral somatosensory stimulation while they were doing core stabilization work on a ball with a band. We had low-level laser and infrared laser affecting the areas of our brain that we thought were relevant. While we were doing complex motions on their left, we were having them squeeze with their right hand. We were having them doing vestibular ocular therapy where they were gaze stabilized, turning their head to the right while we were tilting them with Normatec boots on. And you can imagine there's a lot going on there for the brain, but sometimes it's that specificity that's needed to kick the ball into gear, so to speak, so that their brain can finally start laying down some new tracks so that things can turn around for the better. And until you know exactly what is wrong and what therapy would be most effective, it's hard to layer, it's hard to do anything that's not going to result in, that is going to result in long run change. Because of course, that's what we're here to do. So nutrition and supplementation is perhaps the most important piece for fuel and function, right? We need to make sure that the supplies are there so that they're getting good fuel delivery and the metabolic component is there to make change. We always consider that with our patients. If some patients are very dialed in, some need a lot of work. I think before we move to the nutrition piece, Gigi, we could add the last question.
Okay, let's get it up. So final question, when our eyes stay locked on a target while we move in space, this is called a, so please participate. Let's see if we can get to 100% participation. This is the final poll question. All right, a few more. Okay, we're close. All right, we're going to shut this down in 3, 2, 1. And there are the results, Dr. Helm.
Excellent. That was a little challenging, and I apologize how long I waited to prompt you guys for that. Yeah, so the VOR, the vestibular ocular reflex, is the correct answer. And that just basically means, again, that our eyes are locked on a target. We are moving, but our world is not moving. So you can imagine it's like your eyes need to stay on a fixed object, but your head's turning or your body's going up and down side to side. The polar opposite of that would be an optokinetic reaction. That is to say that something is moving in front of your visual field in kind of a repetitive way, like say you're driving down the road and the stripes are going in the car, but you are more or less stationary in terms of your field. So you're perceiving movement, but you're still. How your brain differentiates those two and to the degree to which it can tell the difference is a huge part of how we help someone feel better if they're having things like vertigo, visual slip, as we discussed, etc. So anyway, moving on to nutrition and supplementation. We do have a few old standbys, things that are more or less given to most of our patients. The NeuroFlam products are primarily what we use. It's considered a med pack. So we include several different key vitamins and nutrients into a packet. It basically just supplements that patients take to create the environment in the neurology that will permit healing, lower inflammation, and promote neuroplasticity. So first one we usually give is Cognicool. This is a Zymogen brand. This is going to help with magnesium levels and promote physical energy and motivation to exercise, right? So we want them mentally sharp. We want them in the right state of mind to handle therapy. So much of, as we know about how enthusiastic we are about care, is a large determining factor in how someone progresses through care. So, it took me many years to figure this out. I'm sure some of our older nurse case managers might know might know that game well, right? So they have to want to get better. So it really helps to have some supplements that get them in the right state of mind to make these changes. So Omega Monopure is our typical go-to for EPA DHA. You guys may be familiar with how our body perceives fat, or the ratios of correct EPA to DHA. Basically, we're looking to give omega-3s and have them adapted in the brain so that we're getting less and less saturation. Basically, if someone were to eat, for instance, only saturated fats, that could be not as great for brain plasticity as someone that is willing or has eaten, for instance, a Mediterranean diet, is getting a good amount of healthy omega-3s. This has to do with the lipid bilayer and the cholesterol and rigidity in the nervous system. Basically, we want to promote health through adaptive change. And when there is exposure to fat in the EPA to DHA correct ratios, we are able to create more adaptive change. So things like fish oil, cod liver oil, krill oil is great. When we give basically EPA DHA, we're always considering krill because of the mercury content, right? So you can imagine bigger fishes have more mercury. Last one is acetylglutathione. So glutathione is, glutathione is our go-to antioxidant. So this is going to upregulate mitochondrial function. We're going to use this to kind of stimulate the energetic component, again, to lay down new pathways to give people a greater therapeutic window. So when we do therapy, we want them to be able to handle it, keep going and keep pushing. And so often the free radical component that we're all attempting to work on and understand today is a factor. So eat your blueberries. Okay, so I want to make this real life for everybody, because usually by the time you've heard this presentation, it's kind of like, yeah, I just still don't understand what the heck is going on. Like, I understand that there's a need case. I understand that people are messed up from concussions and that there isn't really a great plan. I understand this guy does that for a job, but I don't really understand what he does. So I want to go through a case study with you from kind of beginning to end, so you understand the workup, what happened, what she was dealing with as a patient. This was a work comp case, so I think it was a worthwhile check-in, so we can all kind of get back to ground zero here. So this patient, as I said, was a work comp case we did roughly, I don't know, 3 months ago. She came to us with a significant multi-trauma concussion case. So she had unfortunately sustained several high-impact concussions within a very short period of time. And for those of you that know about concussions, you know that that is the recipe for disaster, right? So if given adequate time to rest and repair, recover, heal, you name it, that tends to be what is most impactful and helpful over the long time. If there is multiple insults in the healing period, it can create more long-run situations, more sustained trauma over time, harder adaptability over the long run, etc. So this was a really tough case. She was in a really tough spot. She had really, I don't want to say given up hope, but was at the point where she was, you can imagine the mental component to dealing with, to knowing what your body should be capable of, not being able to get back to it, and being otherwise healthy, and just how incredibly frustrating that was. So, off the top of my head, I recall her primary concerns of being able to comprehend and read appropriately, normal tracking of her visual field, headaches, anxiety, vasovagal concomitants. She couldn't, lightheaded when you stand up too fast, irritability from GI problems to, you could just go right down the list. Everything that could ever happen from a concussion was basically happening to this girl who was otherwise healthy. And so she came to us for a neural workup. We were able to identify key factors in her visual and vestibular system that were specifically not working quite as well as they could be. Targeted therapy was done to improve the way the visual and vestibular system were integrating together to promote normal ocular alignment. So one thing that I really like to point out about this case study is concussions are typically the invisible injury, right? It's very hard from a workers' comp perspective, because it's like, what do you do with that? Someone tells you I have these symptoms and you're like, okay, but your MRI is clean, your X-ray is clean, your CT is clean, you're otherwise healthy, and it's been 6 months and the research tells me that you should be good, right? So it's a very, very tough situation, both for the patient to advocate for themselves, but also for you guys to prove a case about what the heck is happening. So what we have found is that cases that you can literally see a lesion or see a functional problem, like in this case, is worth pointing out for efficacy, and I mean for effect. So on the before there, you can see the abnormal ocular alignment. The patient is having a left esophoria. The reason it's referred to as a phoria is because it's not always like that, right? It does shift back to a functional position forward, but at the moment of pause in that video, you can see the eye is kicked in. That is happening due to a midbrain windup. It's not from her ocular motor system. It's nothing to do with her eye muscles work great. It's her midbrain is basically, you can think about it as like running too hot. It's overstimulated. It's not gating appropriately. It's not having appropriate inhibition. So you're getting a pulling effect in. In that bottom view, you can see this is 3 days later. We had her doing an up gaze in the goggles, and you can see how in the spirit of what was originally happening, her left eye is still kicked in just slightly, but it's notably better, right? So she's losing that fixation where she's pulling in, and she's regaining appropriate motor control. So one very simple task that we could do for this, for home care, which we did prescribe, is a bead string. Whenever you have someone stare at a bead with the string attached to their nose, so they can get some visual feedback about where both of their eyes are relative to each other, and then as well as where that is relative to the vestibular system. So the therapy we did for her involved a lot of coordinated head movements with visual fixation. We did things like hemistim, where we were driving visual input from one side of her body. We were doing things like cold therapy, where we were putting her foot in an ice bucket on the right. We were doing things like vibration and tilt table work to get her to her midbrain wind up to essentially come back into normal range. We did coordination charts and spin chair and you name it. So the therapies are always different, and hundreds and hundreds of applications that we utilize depending on what specifically someone wants addressed and what they're noticing would be most helpful for care. So sometimes our goals as practitioners are not always what the patient cares about. So this young lady happened to really be concerned with her eyes, both aesthetically, but just because she wants to function appropriately. But just because I noticed that might not be her primary complaint. She might be noticing that she just wants her nausea under control. And it becomes a game of communicating how, when we help her gaze to be accurate, she's going to perceive less nausea, right? So there's always that communicative component. So again, bullet points here, the invisible injury we discussed. So the concussion intensive care plans are done very, very close together. We stack these therapies each day, sometimes multiple times a day, in this case, multiple times a day, to create the appropriate change. It's like anything, you want to hit it hard and often to tolerance to really make a lasting improvement for patients. We have found the efficacy over 3 months, 6 months is if we really want to create a long run change for someone, where if we ask them in 6 months, how are you doing? That only happens when you are able to recreate therapy over and over and over again in a very small window of time, so they can adapt and implement the changes. Otherwise, it's like anything, the effect wears off and the momentum is not there, and they go back to their old functioning. So we're really trying to reset software here. Of course, we gave her adequate supplements, home care, and we continue to monitor her home care exercises, making appropriate changes as she heals. So parting thoughts for this: at some level, all rehab is brain rehab. I want everyone to understand that when we work on the systems in the body, and you report with post-meniscal surgery and the patient just like working on his quad to walk again and trust the leg. We've all been there. This is happening at the level of the brain. Everything is about safety, and everything is happening through what our brain perceives as appropriate and what it's willing to do, insofar as it feels safe and trusts what's happening structurally. And that happens in the brain as well with hard lesions, or it can just be something as simple as someone gets shingles in their inner ear, and it screws up their vestibular system, and they have a vestibular hyperfunction, and they're spinning, and they can't stop spinning in their head, and they're not spinning, right? So we have to look at every person in terms of how they are perceiving their environment and how they are feeling safe. And the results just are going to be tremendously different overnight. So that's the paradigm shift I was attempting to put forth today. Everyone is coming to sit at the table of neurology. So if you are a cardiac doctor, or you are a functional med practitioner, or you are a thyroid specialist, all of these things are dictated by the brain and the hypothalamus and your hormones and your the way it doesn't matter. So the brain controls the system. So you have to look at the brain and work on the brain to make adaptive change over the long run. This has been traditionally the hardest thing myself as a practitioner to, at this point in my career, where comp trusts me and as a, refers to us substantially. But, in the beginning, those conversations when you're saying to somebody, you say, I have to work on their ankle to fix their knee, right? And we can understand intuitively as people why that would happen, but according to the system, you can see where the problem would lie. You'd say, well, why aren't you working on their knee, right? So my goal is to bust open the whole region-specific treatment strategies that we see in traditional PT, consider the whole body and why that's so important. It's not because practitioners are trying to milk the system or try to work on the whole body. It's because they need to fix the area of involvement, and that should be obvious to everyone, and I know it is to some. But that has been my personal struggle, and it was a huge hurdle when I was able to overcome that world and gain the respect we need for this therapy. So thank you for that.
So thank you so much, Dr. Helm. I'm stepping in just because there are some really important questions that could be answered, I think, quickly, that would help everybody understand a little bit more. Conservative treatment that I'm used to from head injuries, or what you would term a simple concussion, is rest and medication by most physicians. At what point would you start this treatment post-injury?
Yeah, so 80% of concussions are going to self-heal, right? So you rest, the dark room, the whole deal. Research has changed a lot. Basically, the earlier you intervene, so I should be careful with my words, because technically the best practice is, right, we're getting a CT scan if it's a traumatic brain event, and it's very quick. And assuming there's no structural damage and there's no brain bleeding, and you've gone through the gamut, the sooner the better is the answer. So typically the earlier we intervene and catch these dysfunctional patterns, that is helpful. And certainly it doesn't have to be done that way. Usually by the time patients find us, it's been some time, and that's okay. But the brain does take longer to change when it's taken longer to heal, right? Okay.
And typically you do an evaluation, and how long are your treatments, and for over how many days? I know that every case is different and that you can't really, but just an average, just to give everybody an idea.
Yeah, so the typical neuro reset program, which is done for a standard concussion, if there is such a thing in our program, would be, it's a 10-hour intensive care plan, and it's done over a week. So we see patients for an hour, and then they rest for a half hour, and then they do another hour of treatment, and we do that for 5 days in a row.
Okay, great. If this treatment is done and it resolves the problem, do you ever see the need for additional treatments months later, a year later? How does that work?
Yeah, so the whole idea of neuroplasticity, there should be an inflection point, a period where there's a positive adaptive change and the patient begins healing again on their own. It's really, really important to us that we establish the groundwork so that a patient can make that change so they start healing. So typically we don't see patients again. Oftentimes we unfortunately do for new injuries. However, that is not the intention. So we give them the tools necessary to continue improvement on their own. And we're very specific and thoughtful with the rehab that we feel might be good at home, right? You can imagine like some eye exercises or different vestibular inputs that improve upon what was done to help them speed up their recovery. But the job is done essentially when we've helped them move past that movement pattern, that software default.
And that case study that you showed us, she had treatment for 10 hours and she had problems with, I'm anticipating, dizziness, headache, nausea, it sounded like. What was the outcome of it? Did she have relief of all those symptoms?
She did, yeah. So it was really amazing to see. That was a remarkable case because she was so young. You know, your typical average workers' comp case, naturally, the older we are, the more complications there is in the system. But yeah, she did quite well. She actually emailed me last week about some major life updates. So I was excited to see the progress for her.
That's great. And what also struck me about this treatment that, you know, I have patients that have vestibular problems and have severe head injuries or whatever. It's hard to, for those simpler, in quotation mark, head injuries, it's hard to have objective findings, but it seems like with your evaluation, you're able to determine objective findings.
Yeah,
Is that correct?
Yes, it's proven really important, especially in the auto case industry. The situation is that and I wish, again, if we had more time, I could have dived into that. There's really three major pieces to that. We have the video oculography, which is going to look at saccadic latency in pursuits, basically how well and accurate your eyes are moving. We also are looking at balance in tremendous detail. So sway patterns, elliptical patterns with foam pads without, eyes closed, eyes open, right? We're comparing vestibular function in the balance system. And then also your coordination and timing, so your motor sequencing that's happening on the metronome. And those three systems are really like that's going to give you your data, right? So you can't lie on that. You know, you can't make your eyes move in ways that it's wonderful for both someone to build a case, but also to see progress.
Excellent. So interesting. We could talk for hours about this. For multiple levels of head injuries, but I can't thank you enough for doing this for us today. And I know that some of our nurses have actually trialed this with patients and had good outcomes. So it's really an exciting option. And I think it could be very helpful in the future with concussion management in Massachusetts because, you know, it's an ongoing problem to find the right practitioners and you know, and just finding objective outcomes is great. So thank you so much for joining us today and sharing what you know, and we look forward to hearing more in the future.
Excellent. Thank you. You're very welcome. Thank you guys for listening.
Thank you. So just as a final takeaway, the playback of this webinar will be available within about 48 hours at the end of this session. If you stayed on for the duration of the session, a certificate of completion will be emailed to you within 5 days. The next session in our series is focusing on the spine with Dr. Simeon Zanikos. So if you've not registered, you can do so at www.medicalandlifecare.com/injury-insight. Again, Dr. Helm, this was awesome. Thank you again. And thank you to those who stuck by us, even though we had some technical difficulties. Have a great day, everyone. Bye for now.
Thank you. Bye-bye.
Thank you.